Good morning. My name is Desiree Restad. I am a training developer and manager with the Montana Public Health Training Center. And we're really excited to bring you this training today. We have Sarah Heineman and we have Matt Kelly, who will talk to us about the public health law study, and then also public health law in Montana, what's going on in Montana. So with that, I'll pass it to you, Sarah, and we'll let you start us off.
Okay, great. Well, let me share my screen here. Thank you for inviting me to be here today. I'm excited to be co-presenting with Matt Kelly again from the Public Health Institute. My name is Sarah Heineman. I am a recent graduate of the university's MPA and MPH program in December of 22. I'm also a family nurse practitioner, and I work here at Missoula City County Health Department as the Division Director for Health Services, which are all of our population-based health programs like home visiting, WIC, nutrition programs, and immunizations. So I'm excited to share the project that I worked on as part of my APE and ILE capstone projects, and that's the evaluation of Montana's public health laws and alignments with the foundational public health services. So I do have a disclaimer with this, because this project was the Montana Department of Public Health and Human Services Public Health System Improvement Office requested and sponsored this operational study to help inform public health decision makers on ways to improve public health systems in Montana. The analysis and conclusions of our study represents the thoughts and ideas of the project group and do not necessarily represent the position or conclusions of Montana DPHHS. A couple of quick acknowledgements. This was a group project, so I want to just thank Professor Anthony Johnstone and Professor Anna Conley as our mentors and advisors on this project through the university's Alexander Blewett School of Law. And then Shauna Westcart Gray was my co-author on this project, and she graduated from the MPA MPH program in May. So congratulations to Shauna. Couple of learning objectives just for the purposes of this event. It's to talk about how national frameworks, public health frameworks, can influence or support state public health laws, understand how Montana public health laws align, support, or restrict the foundational public health services, and then bring awareness to a more comprehensive approach that can help support local and state public health infrastructure as we talk about modernizing or revising the public health structure in our state. So the organizational study, this came from the Public Health System Improvement Task Force at the State Health Department. And the background came from concern among individuals across Montana governmental organizations and support organizations that our public health system in Montana may need to be reinvented or modernized. And so that they felt that the study would help decision makers understand the extent of the problem, if there is a problem, and maybe what we might do to address that. So they proposed these three research questions that we used to start off our study with. So how do our current Montana laws align with the requirements of the foundational public health services? Which ones are barriers or constraints that prevent us from realizing the public health services? And then which ones would support or reinforce those principles? And that project outcome was to provide a paper that would distill this information that would be useful to the public health decision makers. And so our timeline started the end of May, I believe, last year, and we worked through the summer and fall with a draft due in October of 22 and a final product due in December to the task force. And so this project includes rules and laws that were up and through maybe August of 22. So this current legislative session that just happened, any changes that were made during that period of time are not included in this paper. So before we could really get started with any of this, I'm going to go back a screen and just talk a little bit why I was really interested in this. It was an intriguing project because it allowed me to be efficient in using it for both capstone projects for the MPA and MPH program. But I work as a public administrator here at the health department, and I regularly have to navigate public health laws. And so it was really an ideal project for me to sort of bring that academic theory to practice to my real world work. And along that journey, get to expand my knowledge and understanding of public health laws and hopefully created a meaningful product for the DPHHS task force. So to get started with this project, we really had to go back and look at some important monumental timelines that impact public health frameworks or structures that would influence state laws. And so we go all the way back to 1998, and that's that landmark Institute of Medicine report that presented evidence that indicated the public health system was in disarray. It's a pretty scathing report about public health and where we were with things. In 1994, the original 10 Essentials of Public Health Services framework was presented as the key to carrying out the mission of public health. And then in 2003, something called the Turning Point Act was passed at the federal level, and this was a voluntary template that states could use to update their public health laws. In 2007, the Public Health Accreditation Board, or PFAB, was created, and that was meant to improve performance and quality of services and to promote accountability. They launched their first version of standards and measures in 2012, so 4 years later, and they really based it off of that 10 Essentials of Public Health framework. In 2007, Montana also updated the public health laws with House Bill 92. It's called Modernizing Public Health Laws. And so we saw to Title 50, Chapter 1, some very specific changes that used language from the Turning Point Act and the 10 Essentials of Public Health Services. In 2013, the original Foundation of Public Health Services framework was presented as the minimum standard or minimum package of public health programs and services that should be available in each community. 2014, the first 2 of 8 Montana health departments completed the accreditation, the national accreditation process. And I believe there's still 8 that have gone through reaccreditation. In 2015, public health accreditation linked that foundational public health services that was created in 2013 and then the original 10 essentials together in their standards 1.5. And then the 21st Century Learning Community began to facilitate statewide work groups so that they could have conversations and facilitate ideas about how public health systems could be improved or modernized across states. In 2020, besides the pandemic, the 10 Essentials was updated, and this was revised to be more inclusive and thorough and to really shift the focus on to achieving equity. And so in the way that we have talked about equity for the last handful of years, really highlighting that as the center focus. In 2021, we had the 67th legislative session, and that one resulted in revising some Montana laws that restricted public health from fully delivering some of those foundational public health services in the areas of communicable disease control, environmental health, and maternal child family health. And we'll talk about these a little bit more as we get to the findings in those specific areas. And then in 2022, the Foundational Public Health Services framework was revised and updated to further clarify the role of government in providing those essential infrastructure to support those minimum packages of public health services. And they emphasized equity. So equity being, this is important, we need to get it incorporated into these frameworks and figure out how to make system changes. So understanding that timeline helps us understand some of the changes that influence our state laws. So when we talk about the Montana landscape and the difference between state, local, and federal government, Matt's going to get into this a little bit more, but the role of the federal government in assuring population health is really limited to policymaking, financing, public health protection, collecting and disseminating information about U.S. health and healthcare systems, capacity building for population health, and direct management of services. That duty to protect public health really falls to state and local authorities, and this generally through what's called police powers. And these include activities such as conducting health assessments, surveillance, testing, reporting, monitoring, collecting data, enforcing regulation, licensing, conducting inspections, educating and counseling, and all of these things can help promote and protect health. So when you look at Montana as a state, we're a decentralized state, meaning we have a state health department and then we have local health departments. And local health departments have their own local rules and governing boards and ordinances, and we're local government employees. We're not employees of the state. Within our 56 counties, we have a variety of the way that health departments are set up across our state. There's some city county health departments, there's county health departments, there's one central district where it's kind of a collaboration of a bunch of small counties that come together. We have 8 tribal health departments, and then we have the state health department. We have concurrent authority between state, local boards of health, and local health officer authority when we administer those Montana public health laws. And then as we do a quick scan of current Montana public health laws, we didn't find any reference to accreditation, the 21st Century Learning Collaborative. We didn't find any specific reference to the foundational public health services or equity in the way that we talk about it today. I just wanted to throw this slide up here. I'm sure that most of you are familiar with the 10 essentials of public health services, probably more so than the foundational public health services, but I think that it's helpful to understand that some of the language from the original 10 essentials, we see some of that almost verbatim in some of the language, like the policy and the purpose and community partnerships throughout Title 50, Chapter 1. And so we know that that was one of the roots for this. So understanding the background of the various national public health frameworks and initiatives helps us to understand our current landscape. So the foundational public health systems, these describe the governmental role and what makes up the minimum package of public health services that should be available in each of our communities. That system dovetails with our 10 essentials, which really serves more as a tool for health departments to improve our performance and quality of service. And then you have our national accreditation through FAB or PFAB, which when these are all aligned, they strengthen performance accountability to the public, and they demonstrate assurance that the minimum package of public health services and programs are available in each community and that we have the infrastructure to support them. So when we look at the foundational public health services, and this is what we were tasked with using for this project to further evaluate whether our laws align, support, or restrict these core public health functions and services. We had to further understand and delve into the definition of these. So this graph shows, or this picture shows you at the top, there's really 3 components of the foundational services. At the top, you have your foundational areas, which are the main buckets or priorities that should be available in every community. The bottom blue blocks, or the foundation that I call them, are really the capabilities, the foundational capabilities that provide the cross-cutting skills and capacities necessary to support the basic public health programs, protections, and activities. So with the foundational areas above and the foundational capabilities, these are what ensure the community's health and well-being and their ability to achieve equitable health outcomes. See the line around the outside of this represents individual communities and that they're unique, and that you might have a program or a service that's available to your community that may not be in another community because it's driven by community needs. And then you see that equity is the main foundation, and it should be woven throughout. So a little bit about the methodology of this project. Was looking was a big project. So Shauna and I first had to figure out how to organize all of this. And so when you think about organizing the Montana Code Annotated and the associated administrative rules by foundational area and then further by foundational capability, it took us a while to figure out what our template was going to be. Our laws are not based in this framework. Like I mentioned before, they have some root in the 10 Essentials and that Turning Point Act. And so we really had to rely on the search function of the Montana Code Annotated and Administrative Rules websites and keywords from each of these areas. I'm not going to read all of these to you, but I'm just putting them up here for you as a reference if you wanted to go back and read them in more detail. But pulling out keywords in the foundational areas, those 5 main buckets, when we were searching for things, you know, you're putting in communicable disease, infectious disease control. And really the definition of this is having timely and accurate information. It's developing community partnerships and relationships, and incorporating them into a communicable disease plan. Are we able to receive labs and reports, contact tracing, case investigation, recognizing and managing outbreaks? There's a notification process available. There's a treatment process for communicable diseases such as tuberculosis, sexually transmitted infections, and HIV. And then in chronic disease and injury prevention, again, having timely and accurate data, having community partners and how they're incorporated into a community plan of prevention, receiving, they really focused here on reducing tobacco use and cessation, and talked about increasing rates of healthy eating and active living. So some broad categories of prevention and wellness. And then when you get into environmental health, timely and accurate information, community partnerships and how we incorporate them into plans, lab testing, inspections, oversight of food protection, recreational sites, drinking water, managing liquid and solid waste, identifying health hazards, protecting from chemical and radiation hazards, participating in board land use planning and sustainable development, and promoting positive public health outcomes in resilient communities. In the maternal, child, and family health keywords, we are looking again at timely and accurate data, community partnerships, how we're incorporating them into a prevention plan that's based on evidence-based early interventions in prenatal and early childhood, and promote lifelong health, positive social emotional development, newborn screenings with wraparound services. And then finally, in access and linkage to care, timely and accurate data, and looking at healthcare systems in the community, inspecting and licensing facilities, and then how to monitor and discipline providers. All of these have components of seeking funding and financial stability, as well as equity throughout. So using keywords from each of those foundational areas in the Montana Code Annotated Administrative Rules, trying to find which laws or rules might fall into those buckets. And you might have laws and rules that fall into more than one bucket. And then from there, we had to break down. So you take an area, say communicable disease to start with, and you have to assess all of the rules that we decided fell into that bucket, whether or not they have the 8 capabilities, and do those rules or laws align, support, or restrict those capabilities. So in access and linkage to care, excuse me, I'm on the wrong slide here. In assessment and surveillance, keywords, again, timely data. Do we have the personnel and technology to support data? Do we understand and use data? How do we identify disparities and inequities in the social determinants of health? We're really using data and that evidence to drive our decisions. Conducting community health assessment. We're creating strategic priorities based on those things. We have access to 24/7 laboratory resources, surveillance for emerging health issues and alerts and threats, and we work with partners on that. So pulling out keywords from that and then trying to further distill and relate within that communicable disease category. With community partnership and development, looking at developing and fostering those key relationships with community groups and organizations, and how do we engage together to create equity throughout the work that we do together, and look for community-driven approaches. And that's where you see the Community Health Improvement Plan coming from the community health assessment in the previous bucket. Then you move on to the equity capability, and this is really about addressing social and structural determinant of health through policy, programs, and services, strategic priorities, and how are we going to achieve equity throughout systems change? And how do we support and train staff so that they know how to incorporate equity into their daily work? Organizational competencies have 5 subcategories. We're looking at leadership and governance. And this is really looking at internal and external stakeholders at a local, state, and national level, and policies, strategic priorities, laws, and that there should be diverse representation on health boards and councils. You look at information technology services, and We're talking about hardware and software for operations and data analysis, and is it confidential? So we're collecting a lot of data through assessment and surveillance. What are we doing with that data and how are we protecting it? You look at workforce development, this should be supporting a diverse and inclusive workforce, staff that have cross-cutting skills and competencies. So how do we support them in acquiring those, developing them and keeping them up to date? Recruitment and retention plan, succession planning, and then training and performance review and holding people accountable to their work. In the financial management, contract and procurement section, you look at, it's all about the money. So budgeting, auditing, billing, expenses, revenues, grants, leveraging funding. And then do you have the facilities and operations to support the resources to do the work? And then legal services. And do we have access to and use legal services for planning and implementing and enforcing public health laws and policies? There's a lot packed into each of these different capabilities. In policy development, it's really looking at public health policy recommendations and are they evidence-based and grounded in law, and how do we educate, advocate, or lobby to support those public health policies. In accountability and performance management, these are really the bumper rails that we operate within, right? So the business standards, laws, and policies of operation. We look at our accreditation standards. We monitor achievement. We use evidence-based or promising practices to drive our interventions. Do we have a culture of quality and quality improvement in our work environment? And are we demonstrating the impact of our efforts and performance are showing the positive outcomes that we say they are? We have emergency preparedness as another capability. So this is really that public health emergency planning for natural disasters, communicable disease outbreaks, environmental emergencies. Do we have the ability to activate emergency response personnel and systems and have an operational plan? Can we promote community readiness and resiliency and preparedness? And do we issue and enforce emergency orders, have access to that 24/7 response action that includes access to the national laboratory resource? And finally, the last capability is communications. And this is all about how do we communicate with the media? So are we communicating with the media? Do we have the ability to write press releases and hold press conferences? What kind of electronic communication tools do we use? Are we using social media? Are we tailoring communications to various audiences and meeting their needs? Are they culturally appropriate? Are they linguistically appropriate and accessible? And then do we have communication plans for both routine and emergency situations? And are we promoting health education? So taking all of those different factors into consideration with our slightly antiquated search function on the state website for the Montana Code Annotated and Administrative Rules. Small snapshot here, and at the end, I don't want to risk leaving the shared screen PowerPoint to go to Google to show you this, but I can do that at the end. On the left is just a quick snapshot of Montana Code Annotated and how those are organized. On the right are administrative rules. Montana codes are the laws or statutes, and the administrative rules are the rules that support those. And then in the middle is just like a small snap of the search function on the web page. So we can go there at the end of this and we can do a search so you can see if you're not familiar what that looks like. So a few definitions that we had to go back to then were the charge of the project. Are the laws aligned, supporting, or in creating a restriction or constraint to realizing the foundational public health services of that framework? And so we defined aligning by having one or more foundational capability in exact or similar terms, whereas support, it provides a general capacity to achieve, but it lacks specificity. So it's not using that exact language, but it could be implied. And then the barrier, constraint, or restriction is in direct opposition of what the foundational capability or area would be. So it doesn't allow us to realize that. So those are the definitions that we had to work within as we were categorizing and looking for information. I'm going to pause because I see there's a chat. Great slides, lots of good information. Great. Okay. So this is just an example then of how we ended up our final product of organizing. So you can see at the top, this is the communicable disease control foundational area. So each of the 5 foundational areas had a multiple page document like this. And then as you look down the left-hand side of this, those are the 8 capabilities. So for communicable disease, there was the 8 capabilities, and then for each capability, were there laws or rules that aligned, supported, or were barriers to fulfilling that capability? And you could have laws or rules in one capability that aligned with, and in another capability supported, and then in another capability were a barrier. And so there are multiple places where different laws could be and rules throughout all of the foundational areas and capabilities. So this was a pretty big lift of organization, and that's what it looked like when we were done with it. So with this was a big lift between 2 of us working on this project together. We did communicable disease control together. We sort of divided that up and worked on it once we had our definitions and our template to work within. And then I took chronic disease and injury prevention and maternal, child, and family health, and Shauna evaluated environmental health and access and linkage to clinical care. So those are the sections and how we divided out this project. Some just general analysis of some things that we found. With the majority of the public health related laws, they're found in Title 50 of our Montana Code Annotated. Title 50, Chapter 1 and 2 really speak to how we're supposed to operate in public health law. So we saw that in Title 50, Chapter 1, 105, Policy and Purpose, that really sort of supports all 5 foundational areas. And in Title 50, Chapter 1, 105, Section 1, this really broadly could imply the capability of equity, because we're protecting and promoting the health of the public by respecting individuals' rights to dignity, privacy, and non-discrimination. It doesn't say equity in the way that we use equity today. These were last revised in 2007. So it's a recommendation that we would consider revising language to support equity throughout the laws in the way that we define equity today, which is still not a clear definition. We all maybe have a slightly different definition of what that means. Title 50, Chapter 1, 106, called Collaboration and Relationships within the public health system. This really does support that foundational capability of community partnership and development. So you see a lot of similarities, generalities of community partnerships. And then the powers and duties, Title 50, Chapter 1, 202, those are the department, and then Title 50, Chapter 2, 116 and 118, these are the local boards of health and local health authority. And those really support the foundational capability of policy development and support. So if we were to go back to some of those key words, we're looking at health policy recommendations. Are they evidence-based? Are they grounded in law? How are we enforcing things? So some generalizations there. When we get into each of the actual 5 foundational areas, the communicable disease control, some of the strengths that we found are in the administrative rules, specifically 37-114, and this is our communicable disease control. And this is where there are the rules about what are reportable conditions, what are the minimum control measures, what are the current guidelines we're supposed to use, how do we conduct case investigation and contact tracing, what's quarantine and isolation mean. It also has vaccination requirements for schools and daycares. One of the other strengths that I noted for these different foundational areas that's not in law or rule is that our state health department does have a strong CD/EPI program and emergency preparedness programs. So they do provide a lot of support at the state level to the local level for these programs. Some of the challenges that we found with the communicable disease foundational area had to do with those legislative changes that were made at the previous 2021 legislative session. So again, nothing that happened in 2023 is included in this project. So House Bill 702, this created a lot of confusion about vaccine status and whether we could use it as a mitigating measure for the spread of communicable diseases excuse me, thinking about in the early days with once COVID vaccine came on the scene, CDC had recommendations that if you were fully vaccinated, you don't have to quarantine. Our state was saying you can't discriminate against people based on their vaccine status. So you either have to quarantine everybody or nobody. And so it created a lot of confusion about what we could and couldn't use with vaccine status. House Bill 257 prohibits governments from requiring businesses to require mitigating measures. And this really kind of came out of, again, COVID, where we had local authorities requiring mask mandates, for example, or physical distancing mandates for public places and events. So now this rule is saying that we don't necessarily have that same authority. There's also some limits in whether we can limit orders that would interfere with or limit, modify, abridge a person's attendance or operation of a religious facility, church, synagogue, or other place of worship. So somehow those places would be exempt from spread of communicable disease. In House Bill 121, this fosters elected officials' accountability to make those public health decisions, whether they have public health knowledge and expertise or not. And Matt's going to talk a little bit more about this, so I'm not going to go into that one in a lot more detail. We know that the pandemic highlighted several cross-cutting infrastructure issues. We know that public health was chronically underfunded and has had short staffing. And so for us to be able to respond in the way that we did to this pandemic and then go through the stress and the trauma of the pandemic and lose more staff and the burnout in the staff, and then like public health is under the spotlight right now. We have some support and funding, but as that sort of fades into the background, that funding tends to disappear. We have antiquated data collection systems, and we have differing data dashboards, and this results in inconsistency across jurisdictions. So we had a dashboard, the state had a dashboard, other counties had dashboards. We're all reporting different numbers. Nothing ever really quite lined up. We had inconsistent rules between counties because we have that local authority, and so we're doing what we think makes sense for our community, which may be different for a different community on the other side of the state, but it's different. So it creates confusion and it feeds into that mistrust across the public. When we talk about chronic disease and injury prevention as a foundational area, we found that there's general support for this in the Title 50, Chapter 1, 101. Generally supports public health services and functions. There's administrative rules that support WIC, Women, Infants, and Children's Program, the Child and Adult Food Care Program, tobacco settlement, which talks about cessation and decreased tobacco use, traumatic brain injury, and controlled substances. So, and then there's also, again, several programs and initiatives that are held at the state health department level that support programs at the local level, though I'll say they are all chronically underfunded. And you're always chasing the money to try to piece together your program to keep it going. So you have the maybe foundational component of tobacco prevention, but your funding limits what you can be successful in doing. In environmental health, Shauna found that most environmental laws aligned or supported the foundational area of environmental health. She noted that the general powers and duties, sewage treatment, removal of filth, the water systems, sewage and waste disposal, and prevention or alleviating biological, chemical, radiological threats, and the ability to make inspections and require actions were all things that she found that supported or aligned with those foundational areas and capabilities. One challenge that she noted had to do with Senate Bill 199, again from the 67th legislative session, and this is the sale and consumption of homemade food and products. And this allows them to offer these products in places like farmers markets without license permits, certificates, or packaging, labeling, or other inspection regulations. And this was called the free, I'll tell you, an act providing for the Montana Local Food Choice Act, which sounds like it should be something different than what it was, right? So if you have someone who doesn't meet maybe the standard sanitary regulations about how a kitchen should be prepped and cleaned, and then is preparing food and selling that food, it increases our potential for foodborne illness and other things. In the maternal, child, and family health foundational area, lots of strengths were identified. And again, some overlap between communicable disease and chronic disease and injury prevention rules and laws. In general, Title 50, Chapter 1 in 202, the administration of public health laws, general power duties to protect the health of mothers and children. We support newborn genetic screenings and related services, those wraparound services. We have the Montana Initiative for the Abatement of Mortality in Infants. There are general guidelines that support services for during and after pregnancy. There's the Fetal, Infant, Child, and Maternal Mortality Prevention Act. We get the Montana Maternal Child Block Grant, which has specific deliverables associated with the maternal child health population and some funding associated with it. There are laws around nursing mothers and infant protection, as well as some family planning services. There are also some very supportive programs, again, at the State Health Department that support the local departments in delivering maternal child services in our communities. One of the challenges that I noted was Title 50, Chapter 20, and this has to do with the abortion laws in place last year. And it really has to do with regulating medical practice that creates a barrier to reproductive health services. And we know that when people cannot access healthcare or reproductive healthcare services, it creates a greater need for other types of public assistance. We already are dismal in our maternal mortality rate, and when people cannot access maternal care or reproductive care, we're going to see that rate go up. Access to and linkage with clinical care. Shauna found that the areas that supported or aligned this foundational area were mostly in Title 50, with licensing and monitoring of facilities and healthcare providers. Title 33 talks about the role of insurance companies, Title 52, family services, and then social services and institutions. What she noted was missing are the language that supports equity, training, and accountability for employees and programs and quality of services. So with that, we fully acknowledge that there are several limitations to this paper and that we may not have fully covered all state public health laws. We might have missed some. Additionally, while trying to be objective in our categorization process as they relate to the foundational areas and capabilities, you might have a different categorization process depending on your own knowledge, perspective, and application of these rules. This paper also did not include tribal specific laws or rules, and it did not include local governance laws or ordinances. And so we really feel that we're unable to say if all the foundational areas exist in every community in Montana. Our findings do show evidence of portions of the foundational public health services throughout our laws and rules. We were able to categorize by those 5 foundational areas. So each of those 5 buckets, we were able to demonstrate there's laws in there that have things that support, align, or restrict. The capabilities with the most consistently referenced capabilities were assessment and surveillance and policy development and support. And the fewest referenced were equity, accountability and performance management, and communications. And I think that that had more to do with the last time our laws were revised, again, we're in 2007, and our language has changed in the last 15 years. So the strengths from what we have in our current public health laws are that they were originally rooted in that 10 Essentials of Public Health Services and the Turning Point Act. So there's a strong foundation there for them. The challenges are that over the last couple of legislative sessions, we've had some statutory changes that result in some restrictions or barriers, specifically in the foundational areas of communicable disease control, environmental health, and maternal, child, and family health. So recommendations. We believe incorporating the current foundational public health systems framework into state law. This will help define our governmental role and responsibility, and it helps set the intent of the minimum package of public health services that should be available to each community, as well as that cross-cutting infrastructure to support those services. If we update the 10 essentials in state law, this will help health departments improve performance and quality of service, And then if we add public health accreditation to state law, this will connect those two frameworks, resulting in improved accountability, a common operating language, and a standardization across jurisdictions. We recognize that updating Montana's laws is only one aspect of improving the Montana public health system. The Public Health National Center for Innovations and Bipartisan Policy Center recommended a more comprehensive approach to updating public health systems to address 21st century's challenges. So therefore, we recommended to the Montana Public Health System Improvement Task Force to consider the following multi-pronged approach. And that laws are one piece of it. So just what I had said, incorporating the foundational public health services and the 10 essentials frameworks with accreditation into our public health laws. But then we also need to do these other things, and that is community engagement and partnerships. So how do we foster relationships that help build trust and community resiliency and improve our community communication and collaboration with our community partners across the board? Our workforce. We need to invest in a qualified and diverse public health workforce and support ongoing efforts for retention and recruitment. Data and information technology. We need to support a robust and modern and interoperable and secure public health information platform. Right now, we're all using probably 20 different programs within our own organization, and very few of them communicate with each other here, let alone with anybody else. And so if we had a system that we could all link into, it would improve communications. Financing, this is the #1 foundational thing. If we value public health, we would invest in public health. And so how do we commit to providing sufficient and predictable and flexible funding that support our programs so we don't have to duct tape everything together to keep things going? And finally, equity. Equity must be woven throughout all aspects of our public health system. It has to be a systems change. It can't just be a buzzword that we talk about. We have to actually do things that change those systems that can help us achieve a process of equity within all of our public health systems. So with that, that's all I have to share about this particular project, but I want to open it up for some discussions and questions about maybe what's next. That seems to be one of the most common questions that come up, that what are you going to do with this now? Well, I'm not a student anymore, so I don't intend on doing anything else with this at this point in this particular role, but there is some interest for other students that are out there. If someone wanted to pick up this project and take it on and update it based off of the most recent legislative session and the changes, that might be worthwhile doing. And Lee Taggart, as the capstone project coordinator from the MPH program, would be the person to contact and communicate with. And personally, I would be happy to share whatever information I can. And I don't want to speak for Shauna, but I'm guessing she would probably be as well. So with that, I'm going to stop sharing my screen unless we want to just pop over to the MCA. Finding a way to amend it in 2023. Yes, Ellen, that's exactly the point. And I think we were chatting before we allowed the audience in that this to me really comes down to where Matt's going to talk about public health authority and what health departments can and can't do in some way, but how we influence policy, right? Do we educate, we advocate, do we lobby? And so how can we be involved to influence those things? Because that's how our laws and rules are created. And we need to be able to speak to those things and educate, advocate, and lobby for them. So
I'll kick things off just to break the ice a little bit. Sarah, I thought I had heard in the past, and I have never been able to find it, that there is specific reference to the 10 essential services in either statute or regs. Did you find anything along those lines, and where is it if you did?
I feel like it's more where you see similarity of words. So if you were to Google the Turning Point Act, that template, that's where you almost find verbatim in the Title 50, Chapter 1. And then there's just a lot of similar words with the original 10 essentials, but it's more in like the policy purpose, the powers and duties, and some of those.
Okay. So there's nowhere where it actually says, it actually references. Okay. Thank you. I have another question, but I'm going to let somebody else go.
Well, this might actually get ahead of Matt's presentation, but let me put it out there while I'm thinking of it. First of all, this is just excellent, and the amount of work that it took is, it's just amazing. The idea that it could probably be amended, and I saw Anna Conley when I heard your first presentation say, "Oh yeah, this could be amended if we can find someone to do that." I think moving forward in terms of how to use the information and where to use it, and I realize I'm being recorded, and that's fine. I don't work for anybody right now, but there's two sides to the way the information gets presented, in terms of whether presenting it to a certain audience at a certain time is going to be a benefit or a hazard. And since I'm seeing, and generally you've just done an excellent job in using those the foundational framework to present it. Nobody here locally is making that up or at the state. So what a good job, what a great approach. But we've always were careful about Title 50, long before we had the current politics or even the politics of 10 years ago. And so when modernization happened in 2007, it was a multi-year project, but much of that time was spent deciding how much to put forward and when to put it forward, and to be so very careful of Title 50. So obviously I'm expressing some pain about what has happened to Title 50. On the other hand, there's a bigger danger, and we're seeing the loss of home rule. I mean, the reason we are a decentralized public health system, which largely a local public differences, is because we are a home rule state, and because that also fits the public health and the different large county differences in Montana. So there are some things that when we present them, like saying that we have inconsistencies across counties. In the current political climate, I worry about that. Yes, we do have some inconsistencies. And when we're not in a pandemic, which is the vast majority of the time, we should have some inconsistencies, because the public health conditions, whether they're a local outbreak or an environmental condition, such as air quality, which is completely different west of the divide than east of the divide, we should have inconsistencies. And I wouldn't even call them that, because what they are is they're locally tailored responses. And I would want to be really careful in the political environment to say, oh, one bad, and you didn't use these words. So this is my caution. It's not a reaction to you, your words, Sarah. It's just hearing them and trying to put on the hat of some policymakers. Even friendly policymakers might say, yeah, you shouldn't have to deal with all those inconsistencies. Well, I can tell you that there's times I wanted our local jurisdiction to be very different than another local jurisdiction, very different. And I would say that was 95% or more of the time, because that's what matched what was going on. And the other thing about local quarantine and isolation powers, the reason historically that Montana went to requiring local health boards back when they did, back in 1901, was through a lot of hardship and pain. And it was because the counties that didn't care about quarantine and isolation, or even exporting their waste into the river, that was more in 1907, but in 1901, were basically, the counties that were practicing quarantine and isolation and those good practices. What they were essentially doing was keeping all the germs to themselves. They were protecting everyone else at their expense, but they had little to no protection from another county who didn't do that. So they wanted at the time, the policymakers, they wanted to have consistencies, that the authority existed. At the same time, there were times where we wanted to have distinctions and differences at the local level. So yes, I know I'm lecturing, but my hair goes up on the back of my neck when I think of inconsistencies, and it's a similar response to what I had when we used to think about even touching Title 50, because I could see current policymakers grabbing that and using that as a way to remove even more home rule and local ability to respond.
I appreciate that a lot, Ellen. And in no way are we advocating for
No.
that or becoming a centralized state. And I think one of the things that the Foundational Public Health Services does with that line around, that's where you really have your uniqueness to each community, and that's important, right? I think that when Matt will start talking about his information, we see the inconsistencies in how things are interpreted and applied from
Yes.
state laws, and maybe that's more of where the confusion comes from, right? So
Yeah.
to do X here, but we're each interpreting it differently. And so and in the pandemic, that things were just very different. We understand why we did what we did here, but nobody, you know, if they weren't doing it over there, then it just, from a public perception, right? There's how come, and then we need to be able to communicate that clearly. So going to the communication process. So it's how do we make that where it makes sense that, well, this is why Missoula did it this way, but Dawson County is doing it this way.
Right.
We're meeting the individual community needs, because that's what we've got to do for those communities. But
yeah. So I think I just sort of went off on that. But in terms of inconsistencies of interpretation, I'm sure we're going to hear about that next. And boy, we sure do have that. Thank you.
Thanks, Ellen. Any other thoughts or questions, or I can turn it over to Matt.
Sarah, I do have one more.
Okay.
So one of the things that we at the Public Health Institute have been thinking about and exploring is, in some states, this is about financing. So some states, state of Washington, state of Ohio, there's others, have really done a very intentional, specific measurement of resources made available for public health. And they've made a calculation of, hey, this is what we need in Ohio to be able to provide the foundational public health services. This is where we are right now. And this is the gap that we have. Legislature, governor, policymakers, how about we talk about bridging that gap? And that's work that's been ongoing for years. And then FAB, just in the last year and a half or so, year and a half, maybe less than that, 6 months, came out with a costing tool that I was hopeful would be somewhat more accessible way, rather than hiring a consulting company that costs hundreds of thousands of dollars, to be able to use that in the state of Montana. But even in looking at that somewhat simplified tool, I mean, I was health officer in Gallatin, and it's not simple, and it's not, and we don't, like, Ohio had kind of a head start because they were reporting some of those expenditures to the state already. In Montana, that doesn't happen. And so you're really starting from scratch. And I'm really a little bit skeptical. I mean, I think we could probably get some larger health departments, but they'd have to have an accountant. They'd have to have, it's not like the health officer could do this in 10 minutes responding to a survey. It would be a big push. And then in some smaller health departments, I'm just wondering if you've given any thought to that, and whether you feel like there's a path forward to really measuring where we are with public health funding, where we should be in order to provide the foundational public health services, and then bridging that gap. And that's a big question, but I just want to throw it out there because I think it's a possible path forward.
Yeah, it is a big question with a big answer. Personally, it's not something that we delved into for this project, but it's something that I've spent time thinking about kind of in a compartmentalized way, specifically with home visiting. And we've seen cuts to home visiting funding across the board, across our state in the last couple of years. And so we created a statewide home visiting coalition, and through creating relationships with key partners, including some legislative champions, we were able to make a difference with this legislative session where we were able to help them invest some money into ongoing home visiting support. And so that's very like piecemeal. We can't do that with public health with because there's so many different parts and pieces of it. But we did some just very non-scientific surveys of the home visiting managers of, here's your current funding, what are your gaps, and got kind of a rough estimate of what's our total gap across the board. And then that's what number we were able to put forward to say, this is what we need to bridge in order for the whole program to function. This is not just, filling the FTE or the caseload. This is having computers and mileage and the things that actually support that infrastructure, right? And so I feel like there's hope with doing that. And I think it all has to do with the way we frame the ask and the language. So bridging the gap is another thing that we've started calling things with access to with Medicaid expansion. We don't use the words Medicaid expansion. We're bridging the gap for healthcare. So I think it has, on a much bigger scale with public health, there's not going to be an easy way to collect that information. And it would really have to be a commitment and an investment across the board, I think, to get that information and data and then be able to compile it. Could be a multi-student project from the university if you didn't want to hire a consultant. But I mean, it is, other states have made it happen. And so we can also learn from them and use the tools that they've created and not have to necessarily reinvent the wheel. But it's a big lift to get it going.
Yeah, thank you. I might connect with you at a later date to continue talking about that, because there's people who are interested in it. It's just a matter of going down a path where you're setting yourself up for success.
Yeah, absolutely.
All right, everybody, I think it's time to get us going again. I'll pass the torch to Matt Kelly, CEO of Montana Public Health Institute. And with that, there you go, Matt.
Thanks, Desiree. It's good to see everybody. It's really helpful to have you all tell us who you are and what positions you have, because it helps me to understand kind of how to calibrate this presentation a bit. My name is Matt Kelly. As Desiree said, I'm CEO of Montana Public Health Institute. I joined the Public Health Institute in July of 2021. Prior to that, for 11 or 12 years, I was health officer in Gallatin County, Montana. And I see some Gallatin folks on this call who I don't think I've met before, because it's been almost 2 years since I was health officer there. But, we at the Montana Public Health Institute, we really try to be there to be some of the connective tissue of our public health system. And so when I became health officer in 2010, we didn't have a public health training center. At least I don't think we did. And we didn't have a public health institute. We really didn't have some of these really valuable connective mechanisms that we have today. So when I was health officer, I became health officer in 2010. I really didn't understand the system because I was new to the state. I was new to public health in Montana, and I really had to kind of hit the road. And I want to acknowledge Ellen Leahy's on this call. It's a little intimidating to give this presentation to Ellen. I mean, Ellen is the one that taught it to a lot of us, most of us. She was health officer, and I remember sitting in Ellen's office when I was a really green public health official in Montana, really trying to understand the system, trying to understand what I needed to know, her and Jane Smiley and some others who were in the system. So Ellen, if I get off track here, bring me back on track. I want to acknowledge your experience and the depth of understanding that you have on this.
Oh, no, thank you. The torch has been passed. That's why I'm listening to you.
So I think one of the things so I was health officer for 10 years and built an understanding of Title 50 and how the public health system, the words on the page. And Ellen and I and Sarah Heineman was around back then, and we all worked together, and we had this understanding of how our public health system worked. We thought that understanding, in a lot of ways, we thought that was enough. what was really hit us in the face really hard during the pandemic is the words on the page are not enough. So what I'm going to talk to you today about is what is set out in statute, how that connects to administrative rule, how that should and can connect to local policy, local authority. If there's anything I want you to leave here with, though, is the understanding that those words on the page are not enough to really make this work. That what we really need is that community engagement. Sarah had a slide where she was talking about the needs, and one of them was financing, and one of them was going back and looking at and revising our public health laws, modernizing our public health laws. The other one was community engagement. You can do all those other things. You can all understand how our public health system works in statute. But if your sheriff and if your county attorney and if your county commissioners, if those folks are on the same page with you, as we saw during the pandemic, all of a sudden it comes time to use that authority. It comes time to pursue that responsibility, and you're left alone, and you don't necessarily have what you need to do your job. And so this presentation is going to, and I apologize in advance, as I tend to not have PowerPoints with a lot of words on the page, but because we're talking about public health law, there are some pretty dense slides here. I'm going to show you my understanding of what public health, how the public health system is set up in our statutes, and give you an example of how that flows through to administrative rule and to local policy. But I want you to walk away from here really understanding that community engagement. That's really that understanding the words on the page is really a first step. It gets you 5 to 10% of the way there. What's really important is that we engage those stakeholders, especially at the local level, in a state where we have a decentralized public health system. And as we talked about in the past, what's true and what was relevant in Bozeman and Missoula during the pandemic was completely different or somewhat different, very different than what was necessary in Ekalaka. And so we, having those local conversations, having those relationships and practicing how the system is supposed to work is a hard lesson that we learned. The importance of that is a hard lesson that we learned during the pandemic. And one of the reasons that we put together at the Public Health Institute, we put together some resources to help people understand it. A couple of caveats here. One is I'm not an attorney. And more importantly, I'm not your attorney. Even if I was an attorney, I would not be sitting here saying this is enough. You need to engage your county attorney. Your health officer, your board of health really needs to have that relationship with the county attorney, because in statute that he or she is your attorney. And so I did put these slides together with the help of Christopher Gray, who is a former chief civil deputy county attorney in Gallatin County. He's also one of the people that taught me the system. He looked over my shoulder and really, so I did have a point of reference, and I did have consultation with an attorney in putting this together. But again, I'm not your attorney. The other thing I would say is you may have seen this before, and I'm a little reticent sometimes to continue to give this presentation. That said, we keep getting asked and people keep showing up for it. And I think continuing to beat the drum and to make these presentations and to help people understand how our public health system works. Now, some of you may have seen this. I did it at the Confluence gathering recently. That's okay with me. The thing is, if you have seen it, if you know this stuff, great. Then you're going to be on our team to get it out there and to start engaging the public and help them understand it. The third caveat I would have is we're really dealing here with the county-based public health system that's in statute that does not contemplate the tribal public health system, which is a big gap. That we're really going to talk about the public health system in Montana. We need to talk about how tribal health works. That is complex. It's not going to fit. It doesn't fit neatly into an hour-long presentation. That's something we're working on, but I do want to acknowledge that tribes are sovereign nations. They have their ability to do this in different ways. And during the pandemic, they showed us that sometimes they can do it better than we can. You look at some of the decisions that Blackfeet made during the pandemic. I just want to put that out there, that I don't want to put this out there as sort of a comprehensive view of everything about public health in Montana. The tribal public health system is really important as well. So some goals today, I want to give you an understanding of some broad state laws and regulations governing public health. We're going to live a lot in Title 50 that Sarah was referencing, particularly the part of Title 50 that gives responsibility and duties, both authority and duties. And there's a difference there to local boards of health and local health officers. We're going to understand the various types. Hopefully you're going to walk away from this with an understanding of the various types of local public health alignment between boards of health and health officers. You can set this up in different ways, even underneath, even within the scope of and the specifics of the statutes that we have. It can look different. It does look different in different counties. And there's nothing wrong with that. There's nothing illegal about that. In some ways, in other instances, and I'll talk about that. We are struggling at the county level in some cases to understand some of the changes made in 2021. Again, we're going to look at some of those changes made in 2021. Again, I'm going to give you an overview of it with the caveat you need to talk to your county attorney, because your county attorney may have different ideas on this. And then we're going to develop some, hopefully you leave here with some capacity to utilize the knowledge of those public health laws to build for the future, to address local public health needs and to engage those community stakeholders. So I think this is pretty elemental, and it really is important though to take a step back and look at how state government works. It really, in Montana, it's very similar to what we probably all learned in what they used to call civics class or social studies. I don't know what they call it now, where you have this three branches of government. You have the executive, the governor, you have the legislative branch, the legislature, and the judicial branch, and they work together in a pretty familiar way in the state of Montana, familiar to our federal system. The legislature produces state laws, aka statutes. You might be called the MCAs, Montana Code Annotated. They can pass laws. The governor can veto them. The legislature can override the governor's veto. And the judicial branch can come in and say, hey, you're all full of baloney. This is not connected to our state constitution, or and so there's those checks and balances between those three branches of government. Oops, sorry about that. And then those once the legislature and the governor, sorry, I am trying to move. There we go. Once the legislature and the governor decide on those statutes and those are passed into law, they typically provide authority to either state agencies or in some cases, what we're going to talk about here, local governments or local jurisdictions to go about enforcing those laws, going about the business of government. And I'll show you some examples of that. State agencies that are managed by the executive branch, and this we'll talk about DPHHS, the statutes will say, the DPHHS is authorized by state law to pursue and abate communicable disease. And then the state agencies are authorized by that statute to write something called Administrative Rules of Montana. Here's some people call ARMS or regulations. And those have the force of law because they're backed up by state statute. The DPHHS in this case would be authorized by the legislature and presumably the governor, but authorized by state law to write these administrative rules. The other way that this can happen is they can grant that authority directly to local government. And it may say to, in this case, some of the local public health authority, much of local public health authority goes directly to local boards of health And local boards of health are appointed by county commissioners. In some cases where they have city county health departments, you have city commissioners who are participating in that. And those local governments, those local boards of health can do their duties to pursue state law through local ordinances, regulations, rules, and policies. And so you can see kind of how this flows from the government, from the state government down to state agencies and local government. So in the bedrock of our public health system, if you're going to read anything in statute, is I would recommend looking at Montana Code Annotated Title 50-2-116, and then go to the -2-118 right after that, and it lays out the powers and duties of local boards of health. This is just a snapshot of that, and it's intended to give you, we'll get into a little bit more of a review of everything that's in 52-116 in a minute, in a few slides down the road. The point here is this is the legislature, as Sarah outlined, and going back to 1994 and 2007 and 2003, went through and they created statutes that said, this is how our public health system is going to work. We're going to have local boards of health. These local boards of health are going to be appointed by elected officials, county commissioners in some counties, in all counties, and then in some counties where there's a city that's big enough to be required to have a health department. So Missoula, Bozeman, Helena, Kalispell, Yellowstone County is a little bit different. Yellowstone County is a district. I'm not going to deal with that in this presentation, but they're going to have city county boards of health, and Title 50 really lays all that out. I'm not going to go through every corner of Title 50, but you can pick it up and you can read it, and you don't have to be a lawyer to understand it. So I would encourage you to do that. 50-2-118 outlines the duties of local health officers. What I would call your attention to is as we look at this, in both of the slides I just showed you, there is the word shall. And the word shall is different than the word should, and is different than the word may. The word shall denotes a duty. You have a duty to do these things. It's not really an optional thing that the local health officers, and in this case, the local boards of health here, the local boards, the Board of Health shall identify, assess, prevent, and ameliorate conditions of public health importance. And this list is the first 3 items on a list that's as long as your arm. And so the important thing that I want you to bring away from this is that even after the changes made in 2021, which I'll get to in a minute, local health officers and local boards of health have substantial and significant duties. They are the heart and soul of the public health system because they control and they have the responsibility to pursue conditions of public health importance in their county, in their jurisdiction. And it's not an option. That's their duty. And with that duty comes certain authority. So once you have this, the state government is saying, okay, we're going to have health departments. We're going to have health officers who are hired to run the health departments, or to at least advise the health departments, and the health officers are going to have these duties. How do you carry it out? How do you carry it out? In this case, I'm just in red. I've highlighted one that we're going to kind of follow this through in one example of how this can and probably should happen. So in the statutes, it says that health officers shall establish and maintain quarantine and isolation measures as adopted by the local board of health. Okay, that's nice. That's nice of them to say that, but how should they be carrying that out? Well, DPHHS, because they're also authorized in legislation, sets out in administrative rule that's devised in a very transparent and formal and sometimes painful way, sets out an administrative rule exactly the details of carrying out how this is supposed to happen. And here you have the administrative rule about investigating a case of infectious disease. And it talks about the local health officer that the local health officer must, and take appropriate, and what I have outlined here is take appropriate steps as outlined in the Control of Communicable Diseases Manual to prevent the control of the transmission of diseases. This is the state health department saying, okay, locals, the legislature has said that you guys are responsible for investigating communicable diseases, and they've told us to help you understand how to do that. We're going to tell you that this Control of Communicable Diseases Manual, CCDM, that's going to be kind of our Bible. That's what we're going to look at when we have a case of measles, when we have a case of, I don't know, whatever, any E. coli. This is what we're going to look for, and we're going to use that as our guide. We're going to pursue those communicable diseases using that as our model. Well, that's nice. I mean, that's nice of them to say that, but it still leaves at the local level a lot of work to do to figure out how you're going to do that, how you're going to use those best practices outlined in CCDM. How are you going to use those to actually deal with that case of tuberculosis that was just reported to your health department? Likewise, the administrative rules lays out minimal control measures. Again, I would highlight the local health officer must. So, flash forward to 2020 when we had the pandemic hitting, and we had a novel virus coming at us. Local health officers had a duty. It wasn't their option. It wasn't something that they could do. They had a duty to employ minimal control measures. It's complicated because it was a novel virus and wasn't in CCDM, but that the administrative rules make clear that there's ways to deal with that. And so the state health department was helping us understand what those minimal control measures look like. So you have all that. This is just an example of the Gallatin City County Board of Health isolation and quarantine policy. It's probably outdated because I stole it from when I was health officer. It's probably been revised, likely has been revised since 2017. But what this is we worked with our county attorney, Chris Gray, who actually helped with this slide deck later on. He's not with the county attorney's office anymore, to really look at the requirements in statute, to reference those requirements in statute, to look at the requirements in regulation. And we would, at the health department, we would provide him, this is what we think as health officer. I'd say, this is what I think we need to do. I want you to go back and look at statute. I want you to go back and look at regulation. Help me write this into a policy that we can actually use so that when we have a case of tuberculosis, we can initiate isolation and quarantine, which we all learned. Most of us, a lot of us knew because we had dealt with it with a stray TB case here or a measles outbreak there. But when you're dealing with this with a pandemic, it becomes much more complicated, and it's much more than a health officer is just saying, okay, you're in quarantine. You also have a responsibility to support that person and to help that person remain in quarantine. It's a huge responsibility. And so having that laid out in local policy is really important because it gives you the backup at a local public health department to say, okay, this is how we're going to do this. Our Board of Health has approved this policy. We're going to follow this. And if you end up having to go to a judge, if you end up having to go to talk to law enforcement, you can tell them, we're following the law. This is how we're following the law. Even better, what it can do, what a policy can do is form the structure for you to practice how to do this ahead of time. So if you have this policy that you've written down, you really have to go and practice it. And one of the ways we do that is through a tabletop where we pull in the sheriff, we pull in the county attorney, we pull in commissioners and say, okay, if we have a TB outbreak like they just had in Roosevelt County earlier this year, how are we going to deal with this? Let's go back and look at our policy. Let's go back and look at administrative rule. Let's go back and look at statute that are referenced in the policy. And let's talk about what the health department is going to do, what the law enforcement is going to do, how the county attorney is going to prepare to deal with this in a courtroom if necessary, and that county commissioners are going to understand this and be able to explain it to their constituents and be on board with it. So before I go any further, I just want to pause. That was a lot. My goal there was to kind of show you how this authority is born at the state level in the legislature, in the governor's office, and how it passes through state government to local jurisdictions. In this case, it was the Board of Health and the health officer. Any questions out there before I go on? Again, looking at how this works, you start at that state level. It is more complicated than this. There are some city governments that typically a county government really can only do what the state legislature tells them that they can do. There is some complexity in this with some city governments and some self-governing governments where they can do things that unless the state tells them they can't do it. I'm not going to deal with that today. I think that for the purposes of this presentation and for the purposes of the public health system, it's just the point here is that our authority and our responsibility and our authority really comes from that state level, from statute. We don't take it out of nowhere. We really hearken back to those state statutes, administrative rules, and hopefully we're putting those into practice through transparent and specific policies that we have at the local level. 2021, we were over a year into almost a year into the pandemic when the legislature started to meet. We all know how controversial it became. We got into a situation, I think, in a lot of cases where some Montanans were waking up to the idea that, hey, wait a minute, the Board of Health can do what? The health officer can do what? And they genuinely didn't know that. It became, when it became controversial during an election year, it became very difficult, contentious situation. We had a new governor in 2021. We had a new legislature in 2021. They came in and there was a number of bills that came forward to make changes to how the public health system worked. But first, before we do that, I think it's important to just take a step back and to review what the system as it is. And again, I say as it is because they did change some things about the system, but the changes they made were specific. I won't say they're limited. They were substantial and they were substantive, but they were specific. It didn't change everything about the system. And I've heard some people say they took powers away from boards of health. That's not true. The boards of health still have really significant authorities, really significant duties. And I think it's really important that people understand that. Montana is still a decentralized public health state, meaning state law gives local communities significant control over public health policy and practice. At state law, Title 50 also says there is the language they use, a local board of health serving every county and in all cities of a certain size. I forget what that size is right now, but it's typically in Gallatin County, Belgrade just became a city of the size, a city of the second class. Is that right, Ellen? Do you remember? Yeah. I think it's the city of the second class. I think it's 5,000 or 10,000 people. Once you reach that threshold, they have a responsibility to also have a board of health, which is typically where you get that city-county collaboration. The city of Bozeman and the county of Gallatin both have a responsibility to have a board of health. They got together years ago and they said, we're going to do this together. It doesn't make sense to have two boards of health. It doesn't make sense to have two health departments functioning. We're going to do this. We're going to call it a city-county health department. That's where that language comes from, and that's how that's set up. And Title 50 specifically makes clear that that's allowed, and that's one of the structures that counties can choose. And then elected officials in those counties, and almost always it's the county commission, where there is a city county health department, it's also the city commission, make appointments to the Board of Health at any time and for just about any reason. Those commissions can also change the composition of their Board of Health. And so when you were hearing during the pandemic that local elected officials did not have control over local public health, that was not true. Local officials always and throughout the pandemic sat on local boards of health in most cases, and also had the authority and the power to decide who was sitting on those boards of health. And so I just want to be clear about that. We heard that significantly during the pandemic, that local boards of health were outside the control of elected officials. That was just not true. Local officials, local elected officials always have had and still do today the ability to appoint and decide who's on the Board of Health, and they can change that when they decide to do that. And again, the authority of local boards of health is found in that Montana Code Annotated. Take that, put it in Google, you can read it. Montana Code Annotated 50-2-116. If you work in public health in the state of Montana, you really need to read Title 50, Part 2. That really lays out how the public health system and what I'm talking to you about today. Here are some of the more substantial duties that the local boards of health shall carry out. They need to they shall identify, assess, prevent, and ameliorate conditions of public health importance. That is a pretty big category of work. Conditions of public health importance. Protect the public from the introduction and spread of communicable disease. Supervise and make inspections for conditions of public health importance. Issue written orders for compliance or for correction, destruction, and removal of those conditions, and bring and pursue actions and issues necessary to abate, restrain, and prosecute the violations of public health laws and local regulations. This is the system that we had before 2021, and it is the system that we continue to have after 2021. These are still the duties assigned to local boards of health. Did not change. Likewise, the local health officers shall make inspections for conditions of public health importance, take steps to limit contact between people in order to protect the public from imminent threats, establish and maintain isolation and quarantine, and pursue action appropriate in court to pursue the rules adopted by the local board or the Department of Public Health and Human Services. These are still the responsibilities of health officers, even after the changes made in 2021. So what did they change in 2020? Well, it's specific, and it's important that we really understand that they're specific and limited. They're substantial. I'm not saying they're not important. They are, but they're specific and they're limited. Before 2021, the Board of Health was very clearly in charge of hiring and fixing the salary of the local health officer. As health officer, I reported directly to the Board of Health. Likewise, the board could adopt regulations that didn't conflict with state law for the control of communicable diseases and to deal with environmental health threats to the community. After 2021, the state law was changed, Title 50 was changed, and it said the board shall recommend to the governing body who the health officer is going to be and may propose for adoption those rules for the control of communicable diseases and environmental health risks. Those are significant. I mean, and they bring up a lot of questions such as, well, if this new governing body who needs to be elected officials, that's the spirit of the law, this new governing body is going to hire the health officer, but the Board of Health has responsibility for pursuing and enforcing public health laws, then who does the health officer report to? Who is the health officer's boss? Fortunately, in most communities that have dealt with this, they've made clear that the health officer continues to report and continues to have a relationship with the Board of Health, and they work together to do this. That is somewhat vague in other counties, such as Gallatin County, where I currently sit, where I think that the interlocal agreement does not follow the spirit of what we have here. And the county attorney very clearly said that he thought, I think he was completely wrong, that the Board of Health had been relegated to become an advisor, purely an advisory body, and that the legislature had taken action to take all the powers they could away from health departments. That was completely not true, but it was said in open public forums in the newspaper in Gallatin County, and it really has thrown things into confusion in Gallatin County in a number of ways. I'll say they've figured this out, that this is still up in the air. I would say that the interlocal agreement in Gallatin County is still a problem, especially when the rubber meets the road and having to pursue these things. In most other counties, I mean, if you look at Lewis and Clark County, Missoula County, where they have that city-county relationship, they've figured this out. And fortunately for most counties where you don't have that city-county relationship, this is a fairly simple, and I'll show you how they've dealt with this, because they don't have that power sharing relationship between the city commission and the county commission, or city commissions and the county commission. My point here is that the changes were significant, but they were limited and they were specific to certain things. And also, and I'm not going to get completely into this because it's complicated, and it really does depend on how local county attorneys are going to interpret it. But the changes made in 2021 made really significant changes to what the authority that anybody has at the local level to compel private businesses, and the language they had to deny a customer of the private business access. It basically said local government was no longer allowed to approve public health rules, regulations, ordinances that got in the way of people buying and selling goods and doing business. There's a lot there. There's a lot of complications with this. There's a lot we don't yet understand. I think the intention here, what this was really, the spirit of this law was aimed at the mask rule, was aimed at those countywide regulations and ordinances that were extremely controversial during the pandemic, to say, no, you can't do that anymore, Board of Health. What it created, though, was, I think, real questions that counties are still wrestling with, where a health officer is dealing with a sewage backup in a restaurant, or surfacing sewage in a subdivision, where somebody is making the argument that because they've seen this, they've heard about this, well, the health department doesn't have any power anymore, I don't have to do this. Well, that's not really true, because number one, what this deals with is local laws, locally driven laws. And so if you're a sanitarian and you're enforcing the FDA food code that's in state, that's tied to state law, state regulation, this does not impact you. What they're really after here is the laws that are passed by local boards of health, or local county commissions, or city commissions, or administrative rule, those sorts of things. If you are out there and you are enforcing state law, valid state law, such as the food code, or the septic rules, those sorts of things, the changes made in 2021 should not hinder you. That said, you may hear that from the public. We have talked to health officers who have said that they have encountered situations where, restaurant owners have said, you can't do anything to me anymore. That's not true. And that's not true. And you might even encounter elected officials and county attorneys who are confused by this, because this is new, and this is sort of emerging practice for how this is carried out. Our interpretation of this, everything that we've said, is it really is focused on limitations to those local rules and regulations, and that's significant. But it's not. It shouldn't get in the way of the work of health departments in pursuing state law and enforcing state law and applying state law. Again, some of this is pretty still being worked out. It says the Board of Health and the health officer can't compel a business to deny customers access to a good or service or the ability to access a good or service. Well, what if you have a sewage leak in a restaurant? That's still happening. It's connected to state law, but it complicates things. It makes things more difficult for local health departments. I'm not going to focus too much more on this. The point here is that there are limitations that have been placed on not just local boards of health, but any local jurisdiction. But those limitations are limited in and of themselves to local regulations. And there is, I think, uncertainty about whether this applies to things that are applied to the entire county, which I think is the language of the law. It's regulations that apply to an entire county versus something that you would do, a health officer order that you would issue toward an individual or an organization that is doing something that's threatening the public health. Again, conversations, engagement with your county attorney are really critical. Getting inside their head, getting them to focus on this before you have a crisis is really important. What didn't change, again, it still says the board shall protect the public from the introduction and spread of communicable disease. It still says that the Board of Health should supervise and make inspections of public health importance. It still says the Board of Health shall bring and pursue actions necessary to abate, restrain, and prosecute violations of public health laws. And again, I'm not going to read all these to you again. It still gives the health officer the duty. It still assigns the duty and to do those things, to really carry out the work of the Board of Health and state public health laws. Rules to live by. I think relationships are essential. We got to develop them early and tend to them regularly. Having conversations with your county attorney, having regular engagement with your county commissioners, working with your law enforcement folks. That may not get you through, but I guarantee you're not going to get through it if you don't have those relationships early. Be available to those policymakers when they need you, not just when you need them. That goes from everybody from a county commissioner to a state legislature to a U.S. senator, a congressperson. Making sure that you're connected to them, you give them your card. You really your health officer or your director is being a resource for them to build that trust. And you're doing that when they need to talk to you about something, but also when you need to talk to them. Start early, do it. Don't wait until the day before a vote or a decision. That goes at the legislative level. You need to build those relationships, having a cup of coffee. Now, here's the thing. I noticed a lot of you are staff at health departments. I think you need to talk to your director, talk to your health officer about this. This is probably on their mind anyway. Don't do it on your own. Really talk to it. And your health officer may have a plan and a preference for probably has a plan and a preference for how this works. Like I said, if you're waiting for the day of the vote or a public meeting at the legislature or a commission meeting, that, likely the decision has probably already been made in their minds or is pretty close to being made. It's very difficult to change it. Listen and respond. When you go to somebody, don't just provide a problem. Don't just say this is a problem. Say provide options and alternatives. Don't just be against something. Provide that solution. And don't ever forget you represent more than yourself. You speak for your organization, your community. This can be frustrating. Health departments have a lot of responsibility. I'll tell you, it's challenging for me during the pandemic. There was so much going on. Sure, there was always the temptation to really let it rip and tell somebody what you were really thinking. Don't do that. It doesn't do you any good. Even when you've got people in your face, people outside your house protesting, that's really getting outside of that professionalism is really what they're after. Always maintain your dignity and in professionalism, because if you don't, you're giving up your own authority and your own respect. Okay, I'm gonna speed this up a little bit. What does this really look like? Before 2021, it was pretty clear cut. We had elected commissions that would appoint boards of health, who would hire health officers, who would direct health department staff. This was somewhat different in some rural communities, many rural communities. I'll talk about that in a minute, but that was generally the way that the flow of authority went. Once in 2021 happened, they added this thing called the local governing body. Often that was the county commission itself, sometimes a mixture of county and city commissions where you had larger communities with city county health departments. Those commissions would appoint the boards of health, and this local governing body would appoint the health officer. It created a little bit of bifurcation, a little bit of uncertainty about who supervises the health officer now. And that's still being worked out. And I think most communities are finding ways to make this work. But this is the changes made in 2021. In some smaller health departments, a lot of smaller health departments, what you have, you don't have a health, like here, you have a full-time health officer who is director of the department. That was the job that I had, the job that Ellen had. In larger communities where you have the capacity to have a full-time health officer. In some smaller communities, you don't have that full-time health officer who is director of the department. You have a part-time, usually a doctor or a clinician, a nurse, an advanced practice nurse, and a PA or somebody with an MPH in the community who is serving as the health officer, but may not be the director, is not the director of the health department. And this creates a little bit more bifurcation because that local governing body is hiring that part-time person. And then the county commission and city commission is usually sitting on the board of health, and they're hiring the department director. In practice, what you have here, those two-way arrows between the health officer and the board and the health department director really becomes, in practice, a very sort of collaborative relationship between those folks. But you can see how this becomes a little bit more complicated as you move through this. And again, here is in smaller and more rural counties where there's not a city-county arrangement. What it really amounts to is the county commission serves as the county commission. They often will be 3 of the 5 members of a board of health, and they will also be serving as that governing body. They'll hire the health department director who will function much like any other department director in the county, and they'll hire the health officer. So those county commissioners who will sit on all 3 of those, they'll be the county commissioners, they'll sit on the board of health, and they'll serve as that governing body. In those situations, it has become, the changes made in 2021 are significantly less complicated because you don't have that power sharing agreement at the top between elected officials. All this is complicated. It's a lot. We have put together at the Public Health Institute a facilitated guide. It's designed to help lead local public health officials walk their stakeholders through this process. It contains many of the slides that I just shared with you, and it includes prompts for conversations about how this would work. The other thing I would say, so if anybody wants this, they can get in touch with us. I can share it with them and I can walk them through it. I'm always happy to do that. We also have companion resources that go along with this, are templates for a resolution, a county commission resolution that really sets forward who the governing body is going to be and is very, very specific about what their authority is, and very specific about what board of health authority is, very specific about what health officer responsibilities are. And we also have a template for an interlocal agreement that can be used. I would say, know your county attorney. Some county attorneys do not like guys like me sending documents saying this is what you should do. Some of them welcome it. Some of them will be off put by it. It starts with a conversation. And if you're interested in this facilitation guide, I'm happy to provide it to you and to walk you through and give you suggestions about how to use it. I would also say it's really important that you connect with Todd Harwell, the administrator for the Public Health and Safety Division. Carrie Pride works in the Public Health System Improvement Office. They are invaluable resources. We work directly with them. If you call me, I will be calling them and talking to them about what you're calling me about so that we're coordinated. They should probably be your first stop. But if we're your next stop, we'd welcome having that conversation, and you should know that we'll be working in collaboration with them. That was a lot, and I probably went a little bit over time, but it's a big subject matter. We're a resource. Call us anytime, and I'm happy to take questions if anybody has them.
I just want to say that that was one of the clearest orientations to public health structure in Montana ever, especially when you consider that the 2021 legislature introduced a lot of mud and lack of clarity into it. That's great. I didn't know about that resource. That looks like a really nice service and product from the Institute.
Thanks, Ellen. It means a lot coming from you. Okay, if there's no questions, I just want to make the offer. I know a lot of you are not lead local health officials, judging. If you want to call us, if your director wants to call us, please. I'll put my contact information in the box. That's what we're here for. Again, the Public Health Institute is really set up to help connect those dots and be that connective tissue in the system. So please don't hesitate to get a hold of us.
Thank you, Matt. That was really, really informational. And you too, Sarah. I really learned a lot today, and I've been in public health for several years and still learning. So that's great. I'm really glad.